All right. We are going to come back live for our National Vaccine Advisory Committee February meeting. Our next panel is Innovative Actions to Improve Adult Immunization. Our panelists will include Dr. Nandini Selvam, Abby Bowness, Dr. Matthew Clark, and Dr. Carolyn Bridges, and Dr. Loretta Christensen will also be on the line for questions. In this last panel of the day, we'll hear about new data and innovative actions to improve adult immunizations. Our speakers include Dr. Nandini Selvam, who's Vice President and General Manager at IQVIA. She'll provide an overview of adult and maternal annual vaccination trends in the United States. Abby Bowness manages the Adult Vaccine Access Coalition and will discuss recent federal vaccine policy coverage changes in Medicare and Medicaid. Dr. Loretta Christensen and Dr. Matthew Clark are from the Indian Health Services and will describe their relatively new E3 vaccination strategy, which stands for every patient, every encounter, every recommended vaccine offered when appropriate. Dr. Christensen is Chief Medical Officer at IHS, and Dr. Clark is the Chief Medical Officer for the Alaska Area Native Health Service at IHS. And Dr. Carolyn Bridges is from Immunize.org and the National Adult and Influenza Vaccination Summit. We'll discuss summit activities to increase uptake of ACIP recommended adult vaccines and influenza vaccine for all ages. Can we bring up the slides for Dr. Selvam? Dr. Selvam, your slides are up. You have the floor.
Thank you so much. Good afternoon, everyone. Thank you for the introduction. I'm Nandini Selvam, and I'm here from IQVIA. Today, we'll be presenting on the results of adult and maternal annual vaccination trends that we got from our data. Next slide, please. So the overall objective of this study was to understand the impact of COVID-19 on routine adult vaccinations. And by this, we mean influenza, pneumococcal, shingles, and Tdap vaccinations during pregnancy. We utilized patient-level claims data from both private and commercial payers, as well as public payers, which included Medicare fee-for-service, Medicare Advantage, Medicaid fee-for-service, managed Medicaid, and cash in all 50 states of the U.S. In terms of the study population, we had access to roughly 260 million adults, and we ended up with a cohort of roughly 60 million after applying eligibility criteria and linking it to the IQVIA claims data to the consumer data, especially since we needed it for social determinants of health variables. I'll briefly go through some key findings and insights, and then we can go through this in much more detail through each of the looks, since I have it broken down by strata. So the influenza annual vaccine rates declined post-2021, while pneumococcal and Shingrix improved in 22, and are likely to exceed or at least reach pre-pandemic levels. The overall reduction in flu happened across age groups, especially in the 65 plus and public insurance. There were widening trends when we looked at it by race ethnicity, specifically among Black and Hispanic versus white and Asian, as well as in the lower income groups. Shingles annual vaccination rates for the age 65 plus, as well as public insurance, Hispanic and lower income groups had not recovered in our most recent look as far as pre-pandemic levels. And then we saw similar sorts of declines, both in pneumococcal as well as Tdap. Next slide, please. Before I jumped into the stratification, this is really a bird's eye view of what we looked at across the 4 vaccines of interest. So even before I talk about the vaccines itself, what is obvious, and that's really the purpose of this slide, is that with the exception of influenza vaccine among the 65 plus age group, the uptake for all of the other vaccines are really less than 50%. I mean, the closest it comes to 50 is among the Tdap vaccines, but if you look at each of the other ones amongst the eligible population, uptake is really low. While shingles and pneumococcal are not annual vaccines, we did look at it in terms of annual views since it provides insight into uptake on an annual basis. So while the pandemic might not have had an impact on vaccine rates, while the pandemic has had an impact, on vaccine rates both up and down, honestly, I believe as a nation, we need to do better because these rates are already pretty low. Next slide, please. So to orient you with this slide, I know it's busy, but this was a really easy way for us to show across the different strata. So what we'll see in each of these subsequent slides is that there'll be a stratification by age group, race, ethnicity, payer channel, urban, rural status, as well as household income. The big takeaway here is that the annual flu vaccine rates over the past 5 years, whatever gains we made during the pandemic and improved influenza uptake for the vaccination seem to be losing some ground, right? So with rates returning towards pre-pandemic levels, you can see a small uptick if you look down at the bottom left around urban rural. But given the split it's very small numbers, so the split is really hard to tell. But it's much more pronounced in other parts when you look at income, if you look at by payer channel, if you look at it by race, ethnicity, age group. So really across the board, really declines. Next slide, please. So what we're attempting to do with this is to give you a view, right, in terms of directionality, but also to give a sense of where maybe public health efforts need to be focused. There are two maps here. The left is for age group 18 plus, the right is for the 65 plus age group. And it really is on a continuum where the darkest of reds show the greatest of declines versus the greens or coming close to it, right? So yellow plus, where there are improvements. And the way we looked at this is that we looked at the percent change in flu vaccine rates from the most recently completed flu season, which is June 21 through May 22 versus prior season. The range was everywhere from 10.6 to a negative 10.6 to a positive 17% across the states and age groups. The general trends we saw among both the 18 and 65 showed that the greatest drops were in the Pacific Northwest, the New England states, and then in New Mexico. But really hard to tell in terms of sort of a generalization because it's really all over the place. You just have to look at the map and take a look to see what it looks like. But it's not a great picture because there's quite a bit of red and orange. Next slide, please. The data we looked at for shingles showed that the annual vaccination improved for the most recent year evaluated by 2021. It's not an annual vaccine, as I previously stated, but annual is a good marker of penetration. Shingrix entered the market in 2018, and the CDC recommendation for it is 50 plus and 2 doses. Now, the only exception for that is if there are immunocompromised, then the recommendations for 19 plus. And what you see across all of the state strata is that there's a spike in activity in 2019 and marked decline in 2020, which it's hard to tell, but it could be a result of both the pandemic, but also a residual supply chain issue from 2018 that was getting corrected in the marketplace. Next slide, please. So this is, again, similar to the flu, right? You see the left is for 50 plus, and then the right is for 65 plus when we're looking at shingles annual vaccination. And what you see is in the younger age group that there seems to be some improvement in about 13 states. But for the older ones, so 65 plus, really there are declines across the board to just different degrees. Not a really good picture for where we're headed. Next slide, please. So here I have 2 slides for the pneumococcal vaccines that look very, very similar. What we were trying to do was, again, just like shingles, we were looking at the 65 plus age group as well as the 19 to 64 for those that are at high risk. So this particular slide view is for the 65 plus. And what you're seeing is general declines in 2021 with some improvement in the most recent year. We see part of the decline, at least in 2021, since 2021 and in part of 2020, perhaps, that resulted in some of these declines could be as a result of clinical decision making, where there was some type of vaccine prioritization happening. So that's one part of the story. If you can go to the next slide, please. Now, this picture for the 19 to 64, the volume's obviously a whole lot lower because this is just the high-risk cohort that we were looking at. But again, similar sorts of trends and potentially vaccine prioritization, but again, across the board, much lower numbers, even amongst the eligible population. Next slide, please. So in terms of the difference in vaccinations for pneumococcal, it shows a much tighter range than we saw with the flu vaccine. The states in the darkest green show the greatest improvements versus those in lighter green and yellow. Now, similar to flu, there seems to be something happening in Rhode Island, right, where, again, it seems to be heavily impacted. So perhaps something for public health authorities to be looking into to see if there was a change in vaccine campaigns or something else that happened. We also see decreases in the Midwest as well as the Western states showing some improvements, but again, still pretty low penetration in quite a bit of places. Next slide, please. And our final vaccine look is for Tdap. So here the data ends in 2021, and the reason for that is that we need an additional 40 weeks from when we start our evaluation period, since we look at it from last menstrual period through the completion of the pregnancy. So if one look at this, even prior to the pandemic, there was not great penetration. There were some improvements that we saw during the pandemic, but that also seems to be decreasing across the board. It's striking that some of the greatest declines that we see in the higher income groups is amongst the highest income group versus the others, but even that is still pretty small. It's roughly about 3%. And we're seeing a slight uptick amongst the public payers versus the private payer covered women. Next slide, please. So this is just like everything else, the heat map for Tdap. And what you're seeing here is that there are areas grayed out. And the reason for that is that we just didn't have enough of a sample size to draw a meaningful conclusion at the state level for some of these pregnancies. And what we do see is that amongst the places that we did have data, the highest increases of vaccinations tended to be in Illinois, Ohio, and Tennessee, and the greatest declines in North Carolina, Nebraska, and Virginia. A lot of information to go through and a very short period of time, so I've rushed through this, but thank you for your time, and I'll pass it back to the host.
Thank you very much. Our next presenter is Abby Bowness from Adult Vaccine Access Coalition. Abby, your slides are up. You have the floor.
Thank you. Hi, everybody. Thanks for having me today. And thank you for all that great data. Again, Nandini, that's amazing. Today, I'm here to talk a little bit about the work that AVAC has been doing and some recent updates in Medicare and Medicaid vaccine coverage policy. Next slide, please. For those of you that aren't familiar with AVAC, we are a DC-based coalition. We've been around since about 2015, working to enhance access and utilization for adult vaccines. We are made up of a diverse group of vaccine advocates, and we include providers, whether doctors, nurses, pharmacists. We have patient groups, we have public health groups, we have innovators at the table, and vaccine specialty organizations as well. Next slide, please. Here's a little snapshot of our 70 plus members. And the thing we have in common is we're all working to improve access and utilization to adult vaccines. Next slide, please. We come together around multiple policies, but here is a layout of some of our core policy goals, which include supporting and strengthening vaccination infrastructure, working to create equitable access for all recommended vaccines, eliminating financial barriers, which is where we'll focus this conversation today, and just overall helping to promote high immunization rates, both in terms of supporting beneficiaries and as well as on the provider side. Next slide, please. And why do we do this work? We do it because we know that not all adults are receiving all recommended vaccines. And even just Recently, CDC did an analysis showing us that 3 out of 4 adults are missing at least 1 or more of the routinely recommended vaccinations. And we know that there's more vaccines coming for the adult space soon. So now more than ever, it's really important for us to be focusing our time and our efforts to think about how to improve vaccination policies. Next slide, please. And I think you're all very familiar with some of the barriers that we face in terms of access to adult immunizations. Again, for today, really honing in on some of those financial barriers, which include whether an individual has to pay for a vaccination or not. Studies have shown us in the past that when there is cost involved, uptake goes down, and there is that direct correlation. So since AVAC was created, that was one of the things that our members had asked us to work on and think about what were the policy opportunities there to make vaccines more accessible and take away that barrier as cost so that we could focus on some of these other barriers. And as you know, those include things like education, provider support, some of the data systems that are there, hesitancy. So we could have all sorts of sessions on some of these other barriers as well. We are working on all of those simultaneously, but for today, really thinking about the financial side. Next slide, please. So just to kind of talk about where some of those financial barriers exist, really there's a coverage that's available, and this is up until now. We will talk about kind of how this system is going to be changing, but about 2/3 of adults currently have access and coverage. And, there really has been a patchwork in terms of the marketplace, in terms of public and private systems that are covering vaccinations. So just to spend a moment here and talk through how people have been getting vaccine coverage to date. There's, of course, the private insurance marketplace. Ever since the Affordable Care Act, there was language in there that said if it's an ACIP recommended vaccination, then those vaccines are covered with no cost sharing. And so that really covers up until anyone in that private marketplace. And then there's been the Medicare program, right? So for 65 and above, you have vaccines that are covered. However, there has been a split. There's the Part B vaccines, which were those that had been written into statute one at a time pre-Medicare Modernization Act. So things like flu and pneumococcal, hepatitis B, that had no cost sharing, and that was written in as part of the statute. But then after 2005, when the Medicare Modernization Act came into fruition, new vaccines were put into that Part D program, the pharmacy benefit. And that really opened up a lot of avenues for the immunization neighborhood and for providers to be offering vaccines. However, there was nothing in that statute that talked about cost sharing. And so what we had is a discrepancy between vaccines in B, where there was no cost, and vaccines in D, where the cost could vary depending on a person's plan or the vaccine. Then there's Medicaid. So, and that is also a patchwork based on state by state. And so what we had is some states had been following, the extended coverage in the Affordable Care Act. Those states had no cost sharing and coverage of ACIP vaccinations. And then there were other states that did not follow that suit. And so they had different rules on immunizations. And so what we know is there's a real vary about whether certain vaccines are covered, how many of the ACIP vaccines are covered, and what the cost is. And so in all, that created a very varying framework in terms of, which vaccines were covered and what cost the beneficiary, the patient, was facing when they go to get vaccines. I would make one note just on the more recent vaccine around COVID-19. Before that vaccine came to market, Congress actually put into statute that vaccine would fall under the Medicare Part B because they did not want cost sharing. There was also work done through the public health emergency in terms of also adding coverage in for Medicaid in the private marketplace. So ultimately, nobody has paid for the COVID-19 vaccination as long as the public health emergency has been going on. Next slide, please. So now let's talk about the recent changes that are going to, bring more parity in terms of vaccine coverage. And we're really excited to share. Last August, the Inflation Reduction Act was signed into law, and that was a very big bill covering a wide range of things. But for the purposes of today, we are thrilled to share that there's actually 2 provisions in there that relate directly to immunizations and cost sharing. And so what we have are sections 11401, which eliminates cost sharing for Medicare Part D vaccinations. And then we also have section 11405, which relates to Medicaid coverage as well as cost sharing provisions as well. Next slide, please. And I guess I should just note that both of those provisions came from standalone bills that had been in Congress, the Protecting Seniors Through Immunization Act and the Helping Adults Protect Immunity Act. The Part D provisions, just to note, those went into effect on January 1st. So, the months leading between August and January, CMS had been very busy getting ready for the rollout of this. But as of now, and as of the start of the year, any vaccines that are recommended by ACIP are available as part of that Part D coverage benefit with zero cost. So shingles, for example, and Tdap would be two examples. As future vaccines come to market, if they're placed in Part D, they would also fall under this provision. And I would just note that for those of you that like to read more about the implementation around this, CMS has released a number of documents, both to the plan sponsors and public-facing documents that are up on their website. There were some fact sheets and frequently asked questions and lots of great materials that are available. Next slide, please. So the other provision that I had mentioned around Medicaid coverage, that will go into effect in October of 2023, so just a few months from now. And this provision establishes coverage for recommended vaccines as well as eliminating the cost sharing. CMS should be releasing guidance around this, so there will be additional details coming in terms of how this will roll out. But from what we know, the process for implementing these types of changes state by state will vary. And so we'll be looking to the states to see how implementation then comes along from there, and whether they're going to be putting into effect legislation or regulation or administrative actions to bring this forward. So, and just a snapshot here from the Kaiser Family Foundation shows us a map of the Medicaid expansion states. So you can get a sense of kind of where some of the vaccine coverage currently differs. And on the next slide, I'll go into that in a little bit more detail. So we can move forward. This is recent data that was released by Avalier, and they did an assessment looking at the existing gaps in vaccination coverage. So here we get a sense in terms of whether a state currently covers all ACIP recommended vaccinations, or whether they have, one or two or otherwise. And so this gives us a really nice idea of what the next couple months could look like and where we should be, helping to monitor and make sure, everybody has what they need to implement these. And this map is around fee-for-service programs. I'll also note that on the next slide, we can move forward, you get a slightly different snapshot where you look at the Medicaid managed care programs. But overall, the maps are pretty similar in terms of the coverage layout. Next slide, please. So as we understand, and research has shown us, that once both of these provisions are fully implemented and people are starting to utilize them, that we will have an opportunity to have 9 out of 10 Americans covered for vaccinations. And that will be just really a huge, huge celebration. So we'll be working towards that and excited to know that that is now where the policy is starting to lead us. Next slide, please. And I will pause here. We obviously still have lots of great work to do together on boosting access and utilization overall, and I'm happy to answer questions on these provisions and the other work that AVAC is doing right now during the Q&A period. So thank you.
Thank you very much, Abby. Our next presenter is Dr. Matthew Clark from the Indian Health Service. Dr. Clark, your slides are up. You have the floor.
All right, thank you very much. I appreciate the opportunity to share with you some information about our new IHS National E3 vaccine strategy. Next slide, please. So what is the E3 vaccine strategy? Simply, it means that We are going to offer every patient at every encounter every recommended vaccine when appropriate. Next slide. The mission of the E3 vaccine strategy is to ensure that no unvaccinated American Indian or Alaska Native person served by the IHS system of care will suffer a poor outcome or die from a vaccine-preventable illness. We seek to accomplish this mission by increasing vaccination rates and reducing the rates of vaccine-preventable illness in Indian country. Next slide, please. The COVID-19 pandemic, of course, has taken a toll both in terms of direct and indirect impacts on tribal communities. Declines in in-person visits, general access to care, and preventive care during the past 3 years have resulted in decreased vaccine coverage in our vulnerable service population. This has been compounded by vaccine misinformation and vaccine fatigue. While nationally there's been a decline in vaccine coverage for all age, racial, and ethnic groups, IHS has also seen a significant decline in routine vaccine coverage rates, which is especially concerning given the historical health disparities among American Indian and Alaska Native people when it comes to vaccine preventable illness. Next slide, please. So our E3 vaccine strategy is really a call to action for IHS programs and staff to amplify our efforts to incorporate vaccination into the IHS comprehensive system of healthcare, which has shown characteristic adaptability in response to recent public health challenges. I'm pleased to report that all ACIP recommended vaccines are provided at no cost for our service population. Vaccination is one of our most effective prevention efforts. Success requires a proactive approach that prioritizes vaccination at every visit using system-based strategies such as supply chain management for vaccines, electronic health record reminders, advanced visit planning, patient education, staff engagement, and a team-based perspective. Next slide, please. So now I'm going to share with you some of the elements of our strategy. Next slide, please. We seek to engage every patient. This includes all age groups from infants through elders and in every season. In order to be effective, we must ensure that all of our patients eligible for care at facilities are granted equal access to vaccination, whether a regular or a transient patient, including both community and non-community members. We want to acknowledge that the spread of vaccine-preventable infectious disease knows no community boundaries. Next slide. Of equal importance is the incorporation of vaccination into every patient encounter. This includes preventive, chronic, and yes, even acute care visits. It should involve patients seen not only in ambulatory clinic settings, but also where appropriate inpatient, ER, and urgent care settings as well. Also, vaccination does not have to be limited to the medical setting, and where possible, we encourage creative ways to enhance access, such as pharmacy vaccination clinics. Finally, we must take advantage of our system strengths and not limit vaccination to the four walls of our facilities. This means that vaccination should be a key element of home visits by our IHS public health nursing and maternal and child health staff, and should also be incorporated into community events, Head Start and school events, as well as mass vaccination events. Next slide, please. We're advocating a strategy to offer all vaccines recommended by the CDC's Advisory Committee on Immunization Practices. IHS tribal and urban Indian organizations have shown remarkable capacity to engage tribal communities during the COVID-19 vaccine campaign. Now we plan to take some of those same strategies and apply them to all recommended vaccines, whether considered routine or recommended in response to public health emergencies such as COVID and Mpox. Of course, this vaccine strategy is subject to appropriate patient-informed consent and autonomy, and we will do our job to educate our patients and respect their wishes. Next slide, please. Finally, the E3 vaccine strategy is intended to maximize vaccine access when appropriate. It's expected that the vast majority of patient encounters will be amenable to vaccination. That said, this strategy is intended to follow clinical indications for each patient, encounter, and vaccine, and respect all ACIP recommended precautions and contraindications. It's equally appropriate that we ensure the safe and correct administration of vaccines every time by taking proper measures to mitigate the risk of vaccine administration errors. Next slide, please. Our operational plan includes 7 elements designed to promote the widespread implementation of the national E3 vaccine strategy. Next slide, please. E3 is envisioned as a grassroots strategy that relies on a bottom-up approach utilizing a reverse hierarchy in which innovation at the local unit, facility, and tribal community level will inform regional and national efforts. This is very much a shots in arms campaign in which no effort is deemed too small. Next slide. To spread the word, we're planning E3 communication saturation across the IHS system of care. This will include internal and external communications with tribal and federal partners, as well as IHS clinical and public health staff. Next slide, please. Next, we seek to engage and collaborate with key stakeholders, including leadership at every level of the agency, staff in clinical and public health disciplines, and especially our tribal and urban Indian organization partners and tribal communities. Next slide, please. To facilitate implementation, we plan to build a resource bank with easy one-touch access to useful tools and hyperlinks, utilizing expertise and materials from entities and individuals both within and outside the agency. This resource bank will grow to include materials targeting clinicians as well as patients and tribal communities. Next slide, please. Following the quality improvement dictate to steal shamelessly and share seamlessly, we will build on one of the strengths of the IHS system of care, which is cross-pollination for the good of the whole of Indian country. Seeking to integrate federal, tribal, and urban Indian program efforts and to learn from both success and failure, we plan to collect and disseminate best practices and lessons learned. This will include proactive outreach to participating sites in our already established COVID-related emerging treatment surveillance network, who have already been sharing similar information on topics ranging from vaccine safety to medication access over the last 3 years, including the IHS Test to Treat and MPOX PrEP initiatives. Next slide. We're also promoting our E3 Champions Challenge, which is a friendly competition for federal, tribal, and urban programs at the community, facility, and even unit level. Through this activity, we seek to encourage innovation, to incentivize effort, and to recognize success. Next slide, please. Finally, we're encouraging programs to utilize and maximize existing process and outcome measures to track the progress of E3 vaccine efforts. This includes the IHS National Immunization Reporting System, as well as regional and local level systems that already track immunizations, including embedded vaccine metrics, which are deployed both at federal direct care sites and at participating tribal and urban Indian organization sites. Next slide. This national strategy was announced on November 17th by our agency Chief Medical Officer, Dr. Loretta Christensen, and we are planning to fully operationalize E3 this year. Next slide. We recognize that the effectiveness of this strategy is going to require prioritization and staff engagement. Its sustainability will depend on a long-term commitment and a systems-based approach. Areas and local facilities are being encouraged to develop and share best practices, as well as lessons learned to ensure that every patient at every encounter is offered every recommended vaccine when appropriate. The ultimate metric will be the trajectory of vaccine coverage rates in American Indian and Alaska Native populations served by the IHS system of care, as reflected in the national level data such as the IHS National Immunization Reporting System. This is a marathon, not a sprint. The success of the IHS National E3 vaccine strategy will be measured in the intermediate and long term, but will require a proactive approach each and every day at each and every facility. I appreciate, again, the opportunity to make this presentation, and I'll turn it back over to you, Dr. Hoskins.
Thank you very much, Matthew. Appreciate your presentation. Our next presenter is Carolyn Bridges. Carolyn, your slides are up. You have the floor.
Thank you so much, Dr. Hopkins. So I'll be talking today about the National Adult Influenza Immunization Summit, which I will refer to as the summit. Next slide, please. So in the way of background, the summit is a multi-sector coalition, a partnership of organizations working together to increase the uptake of ACIP recommended adult vaccines and influenza vaccine for all ages. The summit started in about the year 2000 in response to influenza vaccine supply issues. And at the time, it was started by Dr. Orenstein, who was at that time the director of the National Immunization Program at CDC, and L.J. Tan, who was at the American Medical Association. The current leadership for the summit is the CDC, U.S. Department of Health and Human Services National Vaccine Program, and Immunize.org. The summit is governed by a memorandum of understanding, and then we have a summit organizing committee, which provides input on priorities and in-person meeting agendas. And we have over 130 public and private organizations that participate. Next slide, please. So these are our summit organizing committee members. I won't go through all their names, but we have a very broad involvement of professional nursing, pharmacy, physician organizations, the Gerontological Society, Infectious Disease Society, NFID, Joint Commission, and AMGA. Next slide, please. And the strategies that the summit uses are to help continue engagement and promote engagement of these many organizations who have many issues on their plates. But through the summit, we work to communicate with this very wide range of partners that includes state and local public health, patient organizations, professional organizations, and others. And it also includes manufacturers. And we want to help work together to identify issues of concern that are common across those working in immunizations and possible solutions. And then we work to identify shared key principles and goals, and then can leverage our ability to communicate and coordinate when there are issues that arise of national importance about, say, influenza or adult vaccinations. And then we work to motivate one another and keep immunizations in the forefront of what we're all working on through showcasing and recognizing successful and innovative practices and programs. And for those interested, you can see some of the award winners from the Excellence Awards from the Summit at the website provided. And then lastly, when the Summit partners work to develop tools, we also work to make sure that those are shared and can be modified as needed by others. Next slide. So in addition to those strategies, we convene adult immunization stakeholders, generally in person, once a year. And then we have working groups that meet remotely as needed. And then we conduct weekly webinars to keep our partners all up to date. And additionally, we facilitate the identification of issues that face our stakeholders and how we can take action to improve uptake of ACIP recommended vaccines, and then work together to develop tools, or oftentimes a summit member will take that on themselves in their own organization. Next slide. So now I'm just going to provide a few examples of some of those collaborative efforts that have involved the summit. One of those is one that NVAC is very familiar with, is the standards for adult immunization practice. So as I mentioned, the summit really started off being most interested in influenza, but then incorporated adult immunizations in, I believe it was 2011. And the summit and its partners recognized very quickly that we really needed to update the standards for adult immunization practice and bring it more in line with pediatric practice in many ways, where vaccination status is assessed at every single clinical encounter. So a working group was formed by summit members that included state and local public health, professional societies, and others. A draft was developed, and luckily we had 2 NVAC members that were also on that summit working group, and the decision was made to hand that off to the NVAC, where they deliberated revised, and ultimately those standards became a recommendation from NVAC. Once those standards were available, then Summit members worked to help promote those standards among their memberships. And Summit also has a web page on their website where organizations can support the Summit and also the standards, and also note how they're going about promoting the standards to their members. Next slide. So later on in 2021, as you heard, there's a great deal of concern about drops in adult vaccination during the pandemic. So in the response to that, the Summit then developed a call to action on adult immunizations. CDC sent out a letter also to provider organizations referring to that call to action. And on the Summit website, you can find all the organizations that support that call to action. One addition to the standards for adult immunization practices was really also a call to make sure the providers were really measuring their performance, which we know is a really important step in improving vaccination rates. Next slide. Another example of how this partnership has worked is that some of the Summit members brought to the Summit at large some concerns about lack of detailed guidance on conducting off-site vaccination clinics. And as was just mentioned, of course, making sure that these clinics are done in a very safe manner is really key component of confidence in vaccines. So the Summit, in response to this discussion and concern, developed a checklist for clinics. This had a substantial input and leadership by CDC in developing this. And this best practices checklist then was cleared by CDC, placed on the Summit website in about 2016, and then became a very important tool for planning off-site safe COVID-19 vaccination clinics. So it was a nice tool to have at the ready when the pandemic hit. So in addition to the checklist, there are also principles list for holding vaccine clinics like this, and a set of frequently asked questions to accompany this checklist. Next slide. As Abby mentioned earlier, of course, financial barriers are something that partners often raise as a concern with trying to improve vaccination rates for adults, and that those challenges can be different for different settings. So some partners brought to the Summit some challenges specifically for federally qualified healthcare centers at the time. And so working with the National Association of Community Health Centers, a strategies document was developed to help improve access to vaccines in those settings. And then billing and coding issues are something that comes up also frequently. And so we have additional information about how providers can avoid billing and coding errors. Other members have mentioned how they are concerned that some providers are leaving vaccination to others and potentially not offering vaccination services because of financial concerns. It may not be financially feasible for their practice. So the Summit also developed a document to help providers understand how they can and reasons why they should invest in adult vaccine implementation, and then points them to other tools that may help them make immunizations more feasible for their practice, such as how to avoid coding and billing errors. Next slide. And the Summit also, wants to do other things to help support that infrastructure. The registries are a key part of that infrastructure, as you all know. And so there are also handouts that the Summit has developed to help promote use of those registries and explain to pharmacists and adult clinical providers why they're so important. for the patients, but also important for their practices. We also have seen an increase in the number of organizations that are working in the immunization space, and that's wonderful news. Many of them, however, may not have a lot of experience or resources for developing adult vaccine messaging. And so relatively early in the adult summit work, CDC and others working through the summit developed a quick guide to adult vaccine messaging. And then other communications tools have also been developed. A very recent one is a one-pager that was requested by some of the summit members to help explain in a very succinct way to providers and provide some tips about some recent updates to the adult ACIP schedule. Next slide, please. And lastly, we had our first in-person meeting in November. We hadn't had one for a couple of years due to the pandemic. And these are just some examples of some of the issues that came to the top that were discussed at the meeting. And I'd say one was, how can the summit and others continue to help support the work of the many new community organizations that have stepped up to help with the pandemic and to help improve vaccine confidence in general and interest in adult vaccines. Another issue was, how can we all work together to improve awareness of and utilization of maternal vaccine and adult composite quality measures? How can we continue to make progress and maintain the progress during the pandemic in the use of vaccine registries or immunization information systems? And then how can we support vaccine providers for adults in incorporating new vaccines as the adult vaccine schedule expands? And I will, next slide, last slide. You have my email information there if there are any questions I can answer. Thank you.
Thank you very much, Carolyn. We have any quick questions or comments from those on the line? I do see one from Jeff Dushan in the chat. He asks, Dr. Selvum, does the relative level of drop in flu and other vaccine coverage change depending on starting coverage rates?
So hi, thank you for that question. I did see it. I wasn't completely clear in terms of what the starting coverage rate was. I mean, so we were looking at it year over year, and so it was essentially a drop from the prior season.
Yeah, thank you. Maybe it doesn't make sense. Let me try again. If it still doesn't make sense, we'll just bag it. I'm wondering if, for example, locations that have higher rates at baseline have a differential in the drop compared to states that have a lower rate at baseline.
Absolutely, right. So it's relative to their own state from the prior year, correct. So it's just a change over time for that specific geography itself. So it's not indicative, it's not a one-to-one, you're right, because if they were lower to begin with and then, you know, and even if they showed an improvement, it may still not have caught up with somewhere else that was higher at baseline and may have declined, but still not met.
Thank you.
Tim Cook.
Yeah, great progress in adult immunization, and it was wonderful to see the Medicare Part D funding. And I know Abby and her team worked really hard on that, along with a bunch of other people. So that was fantastic. The question, I had sort of a technical one about the coverage rates for IQVIA. The rates you had for the various vaccines are much lower in some cases than the CDC rates. If you look at the adult VaxFlu or VaxView database, they're much higher. And the CDC is based on a survey, interviews, I guess behavioral risk factor surveillance system surveys, but they had numbers for pneumo over age 65 of 70%. You reported 20. Shingles, CDC has 40. You reported 10. I mean, they're not minor differences. So I just wonder what methodological kind of information could explain the difference. And I kind of wonder whether IQVIA is able to catch previous immunization data Because in the survey, you're asking people, I presume, if they got a booster, and they said yes. But, you know, the numbers are quite different. So it's just like, any ideas why that might be?
Yeah, so that's a great question. So the way we looked at it was on an annual basis. So this isn't cumulative, right? So what we did was we looked at it and said, in any given year, for the people who are eligible for this, how many actually got vaccinated? And so all this was supposed to do was to say, are there changes in trends? Because once you start looking at it cumulatively, it becomes harder to then differentiate up and down. So this was purely for the sake of simplicity, that we were looking at directionality to say what's happening. And so then when you're looking at just the eligible population in any given year, we are looking back in time as well. So which is why my initial population started with roughly 260 million, and we end up with a cohort of about 60 million, is to continuously take that eligibility into account. And so that you'll see similar sorts of things happen both for shingles as well as pneumo.
Yeah. Okay, I figured it was something like that, but it's kind of an underestimate, right? Because people who already got boosted are not going to be getting the vaccine, and I'm just not sure if your method takes that into account.
Correct. So we actually just look at eligible. So if somebody's already had it, then we remove them from our population for that following year. So the eligibility in terms, which is why it says amongst eligible population. Yeah. And then I think there's a question that shows back up for me in terms of the Medicare population and Medicaid policy changes. So yes, we will continue to evaluate this. I will say that our data is much more heavily focused on the commercial versus the other aspects of public coverage. Yeah. We take that on opportunistically, but yes, we will continue to have similar sorts of analyses in out years as well.
Okay. It's historically been very difficult to get at coverage with the surveys that you do, so I understand the pain.
Yeah, I mean, these are large populations, and so as we kind of go through it, it does normalize. It becomes a little bit more generalizable. So even for pockets that aren't greatly represented, I would harness more on the directionality versus sticking to solid numbers.
Yeah. Okay, thanks.
Thank you.
Thank you. Well, I want to thank all the members of this panel. Lots of good information for us to use. And continue to work on strategies to improve vaccination of our populations to improve public health across all of our sectors. Our next presentation is a presentation from Commander Valerie Marshall from HHS on the Vaccine Federal Implementation Plan. Commander Marshall will provide this last presentation to preview the Vaccines Federal Implementation Plan Admiral Levine discussed yesterday. She works in the Office of Infectious Disease and HIV/AIDS Policy at HHS and played a leadership role in developing this report. Commander Marshall, your slides are up. You have the floor.
Thank you. Good afternoon, Dr. Hopkins and the NVAC committee, invited guests, and members of the public. It is my pleasure to present on the Vaccines Federal Implementation Plan. This plan represents an interagency effort, is an interagency product, and was done in the spirit of interagency collaboration. So in other words, we're all in this together. Next slide, please. I'll first start with a bit of context. Vaccination is the cornerstone of public health, and its life-saving potential is unparalleled and unmatched. It is estimated that vaccines prevent 6 million deaths from vaccine-preventable diseases annually. And because vaccines are administered to a large healthy population to prevent rather than treat disease, we want to ensure the highest level of vaccine safety. This was broadly recognized by Congress, who legislated the formation of the National Vaccine Program Office in 1986 as part of the National Childhood Vaccine Injury Act. As mandated in the legislation, the National Vaccine Program is charged with developing plans to describe how each of the various federal agencies will carry out their vaccine functions in a coordinated fashion. This slide shows the history and progression of the national plans. The first plan was released in 1994. The ultimate purpose of the strategic plans and the national vaccine plans is to ensure vaccine safety and reduce the burden of vaccine-preventable diseases in the nation. Next slide, please. The most recent version of the National Vaccine Plan, the National Vaccine Strategic Plan, was released in 2021. It is a 5-year plan or roadmap that articulates a comprehensive strategy to bolster coordination in vaccines and vaccination across the 5 broad goals on your screen. Number 1, foster innovation in vaccine development and related technologies, such as the creation of new platforms, new manufacturing technologies. Goal number 2, maintain the highest levels of vaccine safety. As vaccine technologies evolve, vaccine safety must co-evolve to keep pace. And we saw this during COVID-19 with the VSafe program. We want to increase confidence in vaccines. We've seen this new surge of vaccine hesitancy, increase access to vaccines, and take measures to address equity. And goal number 5, lastly, is to support global immunization efforts. What affects one part of the world today affects the rest of the world tomorrow. Next slide, please. While the National Vaccine Plan provides a roadmap, the implementation plan provides specific actions by federal agencies. It describes who is doing what. And I will provide some examples as we walk through the duration of the presentation. The actions described in the plan, in the implementation plan, align with the National Vaccine Plan across goals, objectives, and strategies. So the 5 goals are the anchors of the implementation plan. The implementation plan was guided by the Interagency Vaccine Working Group and informed through 2 public comment periods. Next slide, please. So again, this plan represents an interagency effort, is an interagency product, and was done in the spirit of interagency collaboration. Here listed are the multiple federal agencies that provided their specific actions and strategies. We have 11 HHS agencies or OPTIVs, as well as the Department of Defense, the Department of Veterans Affairs, and the U.S. Agency for International Development. Thank you to our interagency partners who contributed their time and energy into developing the plan. Next slide, please. I will now briefly walk through sample actions for each of the 5 major goals of the National Implementation Plan. Next slide, please. Goal number 1. The aim of Goal 1 is to promote the development of new vaccines and improvements to existing vaccines. So we have entered a new era of vaccinology, characterized by transformative technologies and manufacturing innovation. We know that vaccines have been very successful at stemming the morbidity and mortality of infectious diseases worldwide. However, there are still no effective vaccines for many serious and potentially preventable infectious diseases. Advances in vaccine technology, including new delivery methods, adjuvants, as well as progress in systems biology, and an increased understanding of the human immune system hold the potential to address these issues through innovation. So one strategy that is developed under goal number 1, which is build upon prior efforts to prioritize new vaccine targets of global public health importance to guide research and development efforts. One specific strategy is to convene scientific meetings and or facilitate collaborative efforts among federal agencies to support the development of vaccines against infectious diseases of public health significance. Next slide, please. Goal number 2, maintain the highest level of vaccine safety. The aim of Goal 2 is to not only maintain the highest level of vaccine safety, but also to communicate the strengths of the U.S. vaccine safety system to providers, to policymakers, and to the public. We know that in the United States, we have a number of safeguards required by law to ensure that the vaccines we receive are safe. So strategy 2.1 is to identify gaps in knowledge and support research on mechanisms of adverse events associated with vaccines and vaccinations. And so one specific action is to support preclinical and clinical research related to the development of safe and effective vaccines for numerous subpopulations, such as healthy adults, pregnant people, infants and children, older adults, immunocompromised persons, and others. Next slide, please. The aim of goal number 3 is to improve vaccination coverage by increasing knowledge of and confidence in routinely recommended vaccines. The increasing spread of misinformation and disinformation and the mischaracterization of science has caused vaccine hesitancy. If unchecked, vaccine hesitancy fueled by misinformation will lead to deleterious outcomes. And we've witnessed the recent resurgence of chickenpox and measles. So this strategy, which is to counter misinformation and disinformation, increase public support for the individual and societal benefits of nature, is driven by the action to disseminate immunization information through as many communication channels as possible. Next slide, please. Goal number 4 is focused on increasing access to and use of all routinely recommended vaccines. Access challenges include patient-level barriers to vaccination, as well as the financial and systems barriers that providers face in providing vaccinations. So strategy 4.1 focuses on making vaccines available in a variety of settings and seizing every opportunity to offer vaccines to those who need them. And that action is to increase vaccines by expanding the number of immunization sites. Next slide, please. Goal number 5 aims to protect the health of the nation by supporting global immunization efforts. Although the vaccines plan is a national plan, the United States is firmly committed to continued collaboration with and support of partners in global immunization efforts as a critical element of the nation's broader health security agenda. The success of the United States national vaccine strategy will remain linked with the success of global immunization activities. And that strategy supports the development of technologies that improve vaccine access, distribution, and equity in low-resource countries during a public health emergency. And one strategy is to coordinate HHS engagement around the G7 Clinical Trials Charter. Next slide, please. So this slide shows some of the strengths of the plan. The COVID pandemic and the recent monkeypox outbreak demonstrate the need for coordinated and collaborative efforts among federal agencies, and the implementation plan casts a vision of collaboration. With increased vaccine hesitancy and mistrust in vaccines, the plan demonstrates formidable actions that federal agencies are taking to achieve national immunization goals. And lastly, the plan demonstrates the federal agencies' commitment to eliminating vaccine-preventable diseases. Next slide, please. While there is tremendous potential in casting a vision of collaboration, there are challenges in implementing the plan, and we've identified a few hurdles. Number 1, developing a cohesive plan with multiple agencies and multiple federal priorities can be cumbersome and challenging. Secondly, the public's perception of vaccines has shifted with the rise of the anti-vax movement. And thirdly, and lastly, we are slowly pivoting or transitioning from a COVID-19 vaccine emphasis to an all routinely recommended vaccine emphasis. Next slide, please. So in conclusion, although many of the activities identified in the Vaccine's Federal Implementation Plan are agency-specific, they may be suitable for implementation by state and local immunization programs, healthcare systems, healthcare providers, and other professional organizations. The implementation plan is intended to coordinate action by federal agencies to protect public health and achieve optimal prevention of disease. Federal agencies will report out on their specific actions via a streamlined progress report. Next slide, please. This is the website where the plan can be found. If you go to HHS.gov, you can navigate from that site. Next slide, please. This concludes my presentation, and happy to take any questions. Thank you.
Thank you, Commander Marshall. Are there any questions or comments from those on the line for Dr. Marshall about the Vaccines Federal Implementation Plan? Lots of miles to go before we rest. Lots of components in this plan that require a lot of collaborative action.
Absolutely. We look forward to working with our agencies to carry out the implementation plan. Thank you.
Well, thank you for your presentation. I see Rob Schechter has his hand up.
Oh, just a quick comment. Thinking about the research agenda around safety, it strikes me that in the past, additional information about the biological foundations around autism has been helpful for the vaccine safety debate, and similarly, NIH or other sponsored research around myocarditis or other conditions looking at components along with or besides immunization, I think could be helpful in informing public dialogue on safety. Thanks.
Thank you for that comment.
Right. I don't see any other hands up at this point. Thank you, Commander Marshall. We'll now move to our federal agency and liaison representative updates. We're going to start with our federal agency representatives, and we'll start with Robert Johnson from BARDA.
Good afternoon. Thank you so much for this opportunity. We've already submitted the formal comments, so I won't repeat all of those activities here, but I did want to highlight three specific activities I thought might be of particular interest. The first is, BARDA continues its close coordination and collaboration with its private sector and interagency partners to support the federal COVID-19 response for vaccines. These efforts include supporting the advanced development and ongoing manufacturing and procurement of multiple vaccine candidates and products. In late 2022, last year, BARDA also supported the Sudan Ebola virus response, working closely with both the Sabin Vaccine Institute and IAVI. BARDA worked with both vaccine sponsors to expedite manufacturing of doses that could be used in clinical trials. As we look to the future, BARDA will continue its plan to support manufacturing efforts to improve preparedness for the next outbreaks by expediting availability of vaccine that could be used in clinical trials. And finally, as we read about the H5 outbreaks, BARDA continues its partnerships as it has for the last 15 plus years to develop better and more rapidly produce pandemic influenza vaccines that can shorten pandemic influenza response timelines and increase vaccine accessibility to ensure the nation is prepared to respond to the next influenza pandemic. So that concludes my comments, so I'll turn it back to you, Bob. Thanks so much.
Thank you very much, Dr. Johnson. Next will be Melinda Wharton from CDC.
Thank you, Dr. Hopkins. CDC has also submitted a written report, so I will highlight just a couple of brief points. The Advisory Committee on Immunization Practices will be having its February meeting as a virtual meeting on February 22nd through 24th. This will be a 3-day meeting, and we will be discussing COVID vaccine-related issues on Friday, February 24th. Other topics that will be covered in the meeting include products for prevention of RSV for both infants and older adults, and use of monkeypox vaccine for use of the Jynneos vaccine for mpox outbreak response. And the agenda for that ACIP meeting is posted online. Secondly, I'd like to highlight a couple of recent publications by CDC on childhood vaccine coverage. In January, CDC published the kindergarten and school injury vaccine coverage and exemption rates for children entering kindergarten for the 2021-2022 school year, as well as the National Immunization Survey data reporting on vaccine coverage by 24 months of age among children born in 2018 and 2019. the kindergarten survey reported an additional 1% drop nationally in coverage for vaccines that are surveyed at school entry. And this contributes to an overall 2% drop since the start of the pandemic. So what this means is that there's more than 275,000 kindergartners who had entered school who are not completely protected against common and sometimes very serious vaccine preventable diseases. The National Immunization Survey data looking at children born in 2018 and 2019 compared to the previous 2-year period, 2016 and 2017, showed increases for many vaccines that the survey assesses, which is great. But there were continued disparities shown with lower coverage and sometimes much lower coverage in specific groups. The survey reported that children without insurance were more than 8 times as likely to be unvaccinated by age 24 months compared to those with private insurance. And there continues to be lower coverage among children living in poverty as well as children living in rural areas. To help address pandemic-related declines in routine immunization, CDC is launching Let's Rise, an effort to help equip partners and healthcare providers with actionable strategies, resources, and data to support getting all Americans back on schedule with their routine immunizations. And there's more immunization about Let's Rise and access to all routine immunization resources and data on CDC's website. Finally, I just want to make a quick note about the influenza season. Of course, it's just the beginning of February, so the season is ongoing, but activity has continued to decline in recent weeks with a what would be characterized at this point as a moderately severe flu season. I will note that the FluView report that just came out today, which includes the week ending January 28th, included an additional 6 pediatric deaths for a total of 97 pediatric deaths reported so far during the 2022-2023 season. So it clearly continues to be very important to make sure that everyone has gotten their flu vaccine. And with that, I'll conclude my report.
Thank you very much, Dr. Wharton. Next will be David Hernser from DOD.
All right. So thank you, Dr. Hopkins. So as others have said, my official Defense Health Agency report has been provided beforehand. I'll make a few comments on it. DOD still has an active vaccine implementation plan for COVID-19 vaccine in spite of some of the setbacks that have occurred in the recent days of who is required to get it, but we still provide it to all active duty, Coast Guard, Guard and Reserve, and also any individual that is entitled to a beneficiary status. And so far, as of January, we had 9.4 million doses that we provided, and we did that through 400 immunization sites for the age-appropriate groups that have been identified by FDA and CDC. We continue to meet the challenges as we change, as the recommendations change, and the way that the vaccines are being provided. And so far, it appears that we're able to meet that challenge adequately and not have to defer people to the civilian sector to receive their vaccines. Moving on to Mpox, we experienced some of the challenges that were mentioned by previous speakers in delivering Jynneos vaccine to the appropriate populations, but through coordination with the CDC and their release of that, we are currently meeting the demand in the groups, and it is actually available at every one of those immunization sites that I previously mentioned. And then finally, recognizing the challenges that a now non-mandatory COVID vaccine have placed on the DoD, influenza vaccine still remains mandatory for service members, and we still are actively pursuing that program for both service members and healthcare workers who are not approved for an exemption. So we anticipate that we'll still be able to satisfy those requirements, although anticipate some pushback from the increased numbers of vaccine hesitant beneficiaries in the military. And with that, Dr. Hopkins, I'll end my comments. Thank you.
Thank you, Dr. Hearn. Sir, you may note there's a question for you from Rob Schechter in the chat.
Okay, I'll check it.
Thank you. And next we have Roxana Deba from HRSA.
You're on mute, Roxana.
Sorry about that. I'm Dr. Roxana Deba. Nice to meet you. It's my second visit to this wonderful meeting. I'll give you just a very brief update on Advisory Commission on Childhood Vaccines, ACCV. You have the written update. So just to highlight, they met 3 times in 2022. And the highlight of the first meeting was they were discussing a draft recommendation to basically increase the annual appropriations for DICP, DOJ, and the Office of Special Masters of the U.S. Court of Federal Claims, which we call the court. In the December meeting, which was the second meeting, Kathleen Stratton, who's a staff member of the National Academies of Sciences, Engineering, and Medicine, presented on a project between DICP and CDC, a jointly funded contract to conduct causality assessment of adverse events following the delivery of vaccines intended for intramuscular administration and COVID-19 vaccination. Finally, ACCV's got 5 vacancies and they're seeking nominations. So if you know anyone who's like an attorney who's interested in vaccine-related issues and not employed by the federal government, please let us know. Please send an email to accv@HRSA.gov. Thank you.
Thank you, Dr. Deba. Next will be Uzo Shikuma from IHS.
Good afternoon. Can you hear me?
You're loud and clear.
Thank you. Good afternoon, everyone. I am the Infectious Disease Branch Chief and the Indian Health Service Immunization Program Manager at the Office of Public Health Support, and we'll be presenting the Indian Health Service update. We also submitted a written report, but I would like to take this opportunity to highlight some key items. To date, our federal, tribal, and urban facilities continue to participate with within the IHS jurisdiction, and to date, we've administered over 2.3 million COVID vaccines. Following the regulatory action by the FDA and the CDC, the IHS rapidly communicated with our federal partners in federal, tribal, and urban facilities about the bivalent COVID vaccine boosters. And we've actively engaged with them in implementing the bivalent COVID booster. Across our 3 surveillance systems to date, the IHS COVID vaccine safety monitoring has demonstrated a reassuring safety profile consistent with other national vaccine safety surveillance systems. Beginning this past spring, the IHS has been working proactively to ensure access to Genuis vaccine to mitigate the risk of mpox in our tribal community. Over 10,000 doses of Genuis vaccine has been pre-positioned across the 12 IHS areas. And on September 9th last year, the IHS announced a mpox PrEP initiative to expand eligibility for Genuis vaccine to include not only PEP, but as well PEP++, but also pre-exposure prophylaxis for at-risk population. In collaboration with our federal and tribal partners, IHS implemented a simple process for onboarding sites to participate in the National Mpox Equity Pilot Program to further expand access to our vulnerable service population. The IHS continuously, routinely surveils for influenza-like illness through our IHS Influenza Awareness System. The 2022-23 influenza season shows an unusually high ILI activity. The activity showed a very early rapid increase, which peaked at week 50 at 5.6% ILI activity, followed by a steep decline. The ILI activity documented in the past 11 weeks are more elevated than the previous 6 influenza seasons that we've recorded. The system also indicates that IHS regions with very high influenza vaccination coverage rates reported low ILI activity for their region in comparison to areas with low coverage, low vaccination coverage rates. You just heard the presentation just a while from Dr. Clark about our E3 vaccine initiative. The IHS continues to collaborate with our tribal federal partners to ensure access to safe and effective vaccine across the age spectrum for American Indian and Alaskan Natives served by the IHS service population. Thank you.
Thank you, Dr. Shkuma. Our next presenter will be Sophie Califano from the VA.
Good afternoon, and thanks for having us on today. We also have a submitted written report that has more detail, but for a few highlights, more than 1.8 million veterans have received a flu vaccine this season. More than 826,535 veterans have gotten their updated bivalent COVID vaccine that we have on record. We updated guidance this year on hepatitis B, MMR, monkeypox, and or Mpox and COVID vaccines to keep in step with CDC and vaccine updates to availability. We continue to monitor vaccine adverse events through passive and active surveillance. VA collaborates closely with the safety team from that presented today. No confirmed signals for bivalent COVID vaccine or flu vaccine to date this season, including in a rapid cycle analysis looking at ischemic stroke risk in all ages and including in persons 65 plus separately. And VA right now is working to share data on vaccination through the IIS and IZ Gateway. And we expect by the end of this month that we'll have more than 40 states and jurisdictions live with reporting of VA administered vaccines out. And that's all.
Thank you, Dr. Califano. I have to say, anecdotally, it's really been nice to see some of those VA vaccines coming through the state registry for my patients. So.
We're happy to see it as well.
Good. All right, it's now time to turn to our liaison representatives, and we'll go back to Roxana Deba. Do you have any other comments, or did you cover everything in your first presentation?
Well, this will be the DICP,
yes,
DICP and BIPIC comments.
Yeah.
Really, is that okay?
Yes, please.
Really quick, BIPIC. They wanted to highlight, they've administered nearly 23 million COVID-19 vaccine doses to patients, 70% to racial and ethnic minority patients. And they've also, out of the nearly 23 million health centers administered at least 9.5 million to COVID-19 vaccine doses. And they have a very, very comprehensive summary. So hopefully everyone gets a chance to read that. And then on my side, which is the National Vaccine Injury Compensation Program update, we continue to process an increased number of claims. And in fiscal year 2022, petitioners filed over 1,000 claims and nearly $196 million was awarded to petitioners. And that was not the $34 million awarded to pay attorneys' fees and costs. And on this countermeasure side, on the CICP, they are making progress. They are in the middle of processing one claim, and they also continue to receive an increased number of claims. They have almost 11,000 claims alleging injuries and deaths from COVID-19 countermeasures. So that's the update. Thank you.
Thank you again, Dr. Deba. Next will be Chris Riegel from HIP. And I don't see Chris on the list here. Let's jump down then to Rebecca Coyle from ARA. If Chris comes on, just send me a note in the chat and we'll pull you back in.
Great, thank you so much. I just wanted to note there's a couple of things included in our report, specifically on data quality and data visualization. I won't go over those, but I did want to call attention to a couple of items that were included in our update, but then also one that wasn't included in our update, but I think is very relevant to today's presentations and topics that were previously discussed. So one of the things I'm really excited to share with all of you is that ARA, along with CDC and HIMSS, through a collective program called the Immunization Integration Program, released its bulk query toolkit. And so what this is it's really a way to provide strategies to help maintain core IS functionality while being able to expand query capabilities to support large-scale population health efforts. So many of you recall particularly during the pandemic and the height of submitting data to the IIS, that many were overwhelmed with the volume. And this is now a toolkit to help jurisdictions and providers manage those large-scale queries to help in those efforts. So we're excited to have that out there. One item that we didn't include in the report, but I think is important, is a companion SOGI technical guidance document. It's now available on our repository. So just by way of background, I think it was noted earlier that oftentimes it's hard to implement things leveraging electronic health record systems, and using the technology is important in identifying populations at risk. So this is one of the areas that in June of last year, the HL7 International Organization released the SOGI data exchange profiles. And again, this was really a short-term technical solution in response to legislation by many jurisdictions that were either requiring or were going to require the collection of SOGI information. So we know that many of our jurisdictions were going to be struggling with this. And so we worked with a number of our community members. So we had over 20 subject matter experts from across our community help review the short-term solution, and then also look at how to prepare a technical guidance document that can really support much larger scale adoption of that. So in December of this past year, we are very excited to have finally published the guidance on messaging sexual orientation and gender identity. And again, that's available in our repository. So if you're looking for any information about how to implement that within your systems, this is a great place to go. And then just as a note, I think one of the things that bubbled up during the discussions about how to produce the technical guidance was really the need to distinguish messaging a patient's preferred name from the other legal names or aliases that might exist. And so we sort of dug into that a little bit more and came up with a way to help message that. So now we have a new companion document that goes with the SOGI technical guidance called Guidance on Messaging Preferred Name of Patient. And again, this is available in our repository. So if you are working in a system that's trying to figure out how to do that, this also provides some solutions for how to implement that within an electronic system. So we're excited to have those items available. Again, those are in our repository. And then lastly, I'll just note that within our report is a non-COVID related dashboard, just a way to display school reports and what that data visualization looks like. So thank you very much.
Thank you, Rebecca. Next, Jean Good from the American Pharmacists Association.
Hi, thanks, Bob. This has been a great meeting. Thank you for the opportunity to be here today. So just a reminder that the American Pharmacists Association represents, is the largest pharmacy professional organization, over 62,000 pharmacists and student pharmacists. We have one article I just want to bring to your attention that's in press in the Journal of the American Pharmacists Association, and it's really an article to try to quantify the contributions of pharmacists during COVID-19. It's written by John Gravenstein, and what he found when we look at the area of vaccines, that pharmacists in this country have administered over 270 million of the vaccines, or 47% of the nation's COVID vaccines, with the other vaccines of 50% of pharmacists, of the vaccines delivered, a pharmacist was involved somehow. The other areas that APHA continues to be engaged in is through vaccine confidence. So we have a newly refreshed website for vaccine confidence if you'd like to look at that. And there is a written report that has that information. We continue in areas of training and education with flu updates as well as ACIP updates. And then lastly, for resources and information, in a partnership with the National Alliance of State Pharmacy Associations, there's updated data on pharmacists' ability to administer vaccines, and especially COVID-19 vaccines. As the PrEP Act goes away, many of the states don't have it codified in state law for pharmacists to be able to give those vaccines. So that's really important new graphs on ages as well as vaccines, especially related to ACIP and COVID vaccines. And so the rest of my information is in my report. Thank you all again for the opportunity.
Thank you again, Dr. Good. Next is Claire Hannon from AIM.
Hi, good afternoon. Thanks, Dr. Hopkins. We did submit a written report, but I'll highlight a few things. This spring, we are going to be holding Vaccine Access Cooperative in-person regional meetings in 8 regions. We're really excited to bring together the immunization program manager in the region in each jurisdiction, as well as partners, including pediatricians, Medicaid medical directors, and pharmacy representatives, with the intention to develop jurisdiction-specific strategies to improve pediatric COVID-19 vaccination rates. We've also established an adult immunization committee to assist and provide federal guidance framework for adult immunization programmatic infrastructure. So we'll be working with CDC in developing guidance and recommendations and sharing resources with awardees as they look to transition their COVID infrastructure, their COVID vaccine staffing into routine adult programmatic activities. We submitted a letter to HHS in November of 2022 that I think is really relevant and has a lot of great information in it around things to consider and impact of commercialization of COVID vaccine and the end of the public health emergency. So there's a link to that in our report. We continue to sort of stay at the table as a stakeholder, as a partner, to make sure that with the impact of the commercialization that we're prepared and programs are getting guidance that they need. We did submit comments, and we did sign on to a Vaccinate Your Family letter on RSV. That was a great session on RSV during this meeting around the monoclonal antibodies. And since they act as a prevention treatment, they act as a vaccine. We are supporting them to be coded as a vaccine so that they can be tracked as a vaccine, and we hope that they would be included in the Vaccines for Children program. There's a copy of that letter as well in our report. And then lastly, I just wanted to mention that we have an Aiming to Inform podcast. So if you're ever interested in tuning in and listening to some of the immunization program managers talk about their strategies to increase vaccine coverage and their public health environment and backgrounds, please check out Aiming to Inform. That and other resources are on our website. Thank you.
Thank you very much, Claire. Next is Kim Martin from ASTO.
Hello, and thank you very much for the opportunity to provide updates on behalf of ASTO. We continue to support our members by providing situational awareness and technical assistance. Recently, we have developed a few blogs on partnering with community action agencies and healthcare providers to promote vaccination efforts. And like AIM, we have developed several new daily podcasts featuring many of our members and leaders in the field. If you're interested in listening in on those daily podcasts, you can check it out on our website or wherever you receive your podcasts. In addition, we are conducting a Vaccine Hesitancy Policy Academy. This policy academy is intended to help state and territorial leaders prepare legislators for vaccine-related sessions, explore policy options, and to communicate effectively to vaccine-hesitant populations. We are also working with key partners and organizations in 5 communities to reduce racial and ethnic disparities in vaccination rates and to increase knowledge and trust in vaccines. This is the second year of working on this project, and this year our focus is reaching those living with mental or physical disabilities. And the lessons learned from these pilot sites will be shared broadly with our members. In addition, we continue to work with ONC and partners on a learning community to support data sharing and partnerships between state IISs and HIEs. And finally, we continue to collaborate on a multi-year project to support public health agencies with data that can be used to enhance their communication efforts surrounding COVID-19. We are doing this in partnership with the Harvard Opinion Research Program, NVAC, and CDC. And to date, we have released 4 public opinion surveys to gain perspectives on trust in public health and vaccination. We have also launched a learning community to enhance knowledge and provide promising practices to state health agencies. And I think that's all of my updates, but like others have mentioned, more information can be found in our written report. Thank you.
Thank you very much, Kim. Next is Amy Maxson from NACCHO.
Hi, thank you, Dr. Hopkins. As with others, we have submitted a full written report, so I will just pull out a few highlights. First, we have 2 conferences that are upcoming. In April, we're hosting the 2023 Preparedness Summit in Atlanta, Georgia, and some of our vaccine hesitancy funded sites will be speaking at that conference on their projects. We also have our annual NACCHO 360 conference coming up in July, and that will be held in Denver, Colorado. And this year's theme is elevating public health practice for today and tomorrow, and talking about how to move forward in the midst of the crisis while implementing traditional and innovative approaches to restructure the system. So registration is open for both of those conferences now. And then last July, NACCHO held a national stakeholder consultation meeting on influenza vaccination in older adults. And this meeting was a follow-up to a convening that was held in 2021, and it included a number of partner organizations in the older adult vaccination space, a number who are on the call today. And these sessions included presentations from CDC, local health departments, and other organizations. The group discussed goals in the areas of access, communication, data and reporting, and policy. And a summary of the report of the meeting was developed and is now available on our website, and the link is in our written updates. NACCHO continues to operate a number of CDC-funded vaccine projects, and through these projects, local health departments are receiving funding to conduct CDC's rapid community assessment, to ensure equitable access to vaccination for priority populations, and to develop vaccine education and communication campaigns, among other activities. NACCHO also participated in a HRSA-funded project with AIM, the Center for Global Health Innovation, and Johns Hopkins University. And with the project, over 100 community health workers were deployed to build COVID-19 vaccine competence in vulnerable and medically underserved communities. And as part of this project, NACCHO developed a micro website that houses a resource repository for community health workers, but it's also available for partners and for the general public. And the link to that site can also be found in our written updates. And then the last update that I will mention is that NACCHO is currently fielding a survey of local health department immunization programs to get updated information on their current activities, services, get that data on how they've been impacted by the pandemic, what needs and challenges they may have, as well as what best practices they have and what's worked for them. So we look forward to getting that data, and we'll definitely share it as we have that collected and are able to get that out. So the rest of our updates are in our written update, but that's all I have.
Thank you very much, Amy. Next is Heather Dean from the Public Health Agency of Canada.
Good afternoon and good day to everyone. We had submitted a written report, but I would like to highlight that right now we continue to engage with our provincial, territorial, and Indigenous partners to review the lessons learned from the COVID-19 vaccine rollout experience and leverage many innovations and developments that we've had in all aspects of our immunization programs to support and actually optimize our routine immunization programs, and to also inform strategic pandemic planning in the future. We are going to be engaging in discussions to renew our national immunization strategy, and this is an opportune time as we reflect on our experience during COVID-19. We have shared the details in terms of our rollout experience, and we continue to ensure the provision of vaccines for booster dose indications. And currently our NACI, our National Advisory Committee on Immunization, is reviewing those recommendations and will be updating that advice for the spring and going into the fall seasons. Just to also add, actually, we do have a Canadian Immunization Conference that we'll be holding in person this year in Ottawa. I'm hopeful. The time of year is April 25th to 27th, and I'm hopeful that we will not be in the polar vortex that we are in today, where we are experiencing extraordinarily cold temperatures. And that's saying something from Canada, but we hope that we'll encourage our international colleagues to come up to the conference and be able to partake in networking and the latest in immunization research and discussion around immunization delivery programs and vaccine development activities. So with that, thank you very much for this opportunity to share some of our highlights.
Thank you very much, Dr. Dean. Our next presenter is Hannah Al-Saleh from VRBPAC.
Good afternoon, everyone. Since September 2022, VRBPAC met 3 times, but the last meeting was prior to the deadline for submitting. So I will touch briefly upon that meeting. On the 22nd of September, the committee met in open session to discuss the BLA from Rebiotics for a product called Rebiota, which is fecal microbiota live, with a requested indication to reduce the recurrence of C. difficile infection in adults following antibiotic treatment for recurrent C. difficile infection. The committee voted 13 yes versus 4 no in response to the question if the data are adequate to support the effectiveness of the product for the indication, and voted 12 yes versus 4 no versus 1 abstain in response to the question if the data are adequate to support the safety of Rebiota for the specific indication. On the 6th of October, the committee met again in open session to discuss the strain selection for the flu virus vaccine strains 2023 Southern Hemisphere influenza season. The committee voted unanimously for the inclusion of the A. Sydney for the pandemic 09-like H1N1 virus, the Darwin for the H3N2-like virus, the Austria for the B. Victoria lineage virus. For the Yamagata lineage, the committee voted 12 yes, 2 no, 2 abstain to include the B. Fuquet for the as the second influenza B strain in the vaccine. On the 26th of January, the committee met in open session and discussed the future vaccination regimens addressing COVID-19. After a review of available data, the committee voted to simplify and harmonize the regimens available to the public. However, the vaccine composition itself was to be determined at subsequent meetings based on additional data. Happy to answer any questions.
Thank you, Dr. El-Sali. All right. Any other questions or comments for any of our federal agency or liaison representatives? I do see one for Kelly Good from Molly Howell in the chat. If you will glance at that, please.
So there are some concerns, right? If the state doesn't allow pharmacists to administer within that state for COVID-19 vaccines, then pharmacists would not be able to do it. Now, it may change some of the laws, and the states have ACIP recommendations. So with the addition of the COVID-19 vaccine to the schedule, then that may change that and allow pharmacists to do that, because then it would be under ACIP recommended vaccines, which would help. Hopefully, Molly, that answers your question.
Yeah, I was more wondering about to go into pharmacies. My understanding is with the federal emergency that there was some sort of clause that then allowed pharmacists to bill for the administration fee for vaccines given in long-term cares. And so I was just, I'm trying to think ahead for long-term cares and future vaccines, RSV, flu, and COVID, how that will work after the emergency ends if pharmacists can no longer bill for that administration fee.
They should be able to, because certainly we can bill for influenza and other vaccines. So that as long as that's recommended or ACIP and there's a mechanism for other providers to bill, pharmacists should be able to do that as well, but not always. So that could be a concern.
All right. Thank you for that important discussion. Any other questions or comments before we move to our public comment? Hearing none, it's now time for public comment. I understand we have a public comment registered from Mr. Jersey. Is Mr. Jersey on the line, please?
Mr. Jersey, can you dial *6?
Yes, I'm unmuted. Hello, I'm Jester Jersey. I'm here.
Okay, Mr. Jersey, you have the floor. You're unmuted. Thank you.
Thank you, Dr. Hopkins. Thank you. My name is Jester Jersey, and I want to start by stating I have no pharmaceutical affiliations nor conflicts to disclose. Good afternoon, NVAC Advisory Committee. Thank you for allowing me to speak today. I want to comment and suggest a strategic recommendation to increase vaccine rates. I believe vaccine campaigns can be more effective by working with community-based fraternal service organizations. I suggest this because I volunteer for one such fraternal-based community service organization called Kiwanis, and I also volunteer for several organizations promoting vaccine-positive messaging, not just COVID, but other vaccine-preventable diseases too. Last year, the World Health Organization and UNICEF noted that global childhood vaccinations saw the largest declines in 30 years, mostly due to the pandemic. National news outlets have also reported low vaccine rates for flu and COVID boosters in the U.S. For the last 2 years, I've advocated for government collaborative efforts with service organizations. Before that, I worked with Kiwanis on the Eliminate Maternal and Neonatal Tetanus Project, dubbed Project Eliminate, a global joint effort with UNICEF. Within a span of 2 decades, from 1999 to 2022, countries significantly at high risk from tetanus decreased from 59 to 12 nations. Although Kiwanis has helped address global vaccine preventable diseases, they've been active in national efforts in the U.S. too. In the 1980s, Kiwanis worked with Nancy Reagan during the Ronald Reagan presidency on the Say No to Drugs campaign, influencing many young Americans to live drug-free lives. Because of our past health campaign experiences, we can help increase vaccine rates too. I not only recommend Kiwanis, but other national community-based fraternal service organizations. Together, along with Kiwanis, the following organizations collaborated on a joint statement to address COVID during the pandemic. This includes Rotary, who has worked on polio efforts since 1979. Also, Lions International has been addressing vision health for almost a century by collecting donated glasses. Lions' own historical roots sprang from the need to provide better health care to factory workers in the early 20th century. Lastly, Optimus International is active in many childhood wellness efforts. Not only are we trusted in communities nationwide, but we can relay important health information to the communities we serve. Together, we can build community trust through vaccine confidence, reach communities on a personal level, and leverage trusted community messengers. For this reason, I'm making a recommendation to the National Vaccine Advisory Committee, the Department of Health and Human Services, as well as the Centers for Disease Control and Prevention, other federal health departments, and even President Joe Biden's administration. Please reach out to community-based fraternal service organizations for help with vaccination efforts. Together, we can help fellow Americans nationwide. Thank you for your time and consideration, and for the work you do protecting the lives of fellow Americans. Stay safe and have a nice day.
Thank you, Mr. Jersey. We appreciate your comment. And we do not have any other public comments on the line.
That's correct.
All right. Well, hearing none, I want to thank all of you for your participation in our February 2nd and 3rd, 2022 NVAC meeting. I think I've learned a great deal and hope all of you all have also. It's been a very fruitful meeting. Look forward to continuing to work with our subcommittees as we work on the vaccine safety report as well as the innovation report, and look forward to seeing many, if not all of you, at our June meeting as we have posted. At this time, I will call our meeting adjourned and wish you all a quiet and pleasant weekend.
Produced by the U.S. Department of Health and Human Services.